Starting with the renal system, uh, looking at the embryology first, the first thing to know is that we have in the embryology of the renal system three main parts. First is the pronephros, the second is the mesonephros, and the metanephros is the third and the last. So the pronephros is the first thing to develop and is going to be degenerate. So it's completely goes away, and that's why it looks like this. That's why it's called degenerated over here. The second part is the mesonephros. It functions for a brief time, and then it loses function and changes by time into some small parts of the mature urinary system. And then the last thing that is going to develop throughout life is the metanephros over here, and it has two main subtypes or sub points or sub classifications. So let's take a look over here. So the pronephros, as we said, is the it occurs or start to develop in the week 4 of development. It shows up in the week 4 of development. Then it's degenerates, so it completely goes away without any benefit for now. So while the mesonephros, it also starts in the week 4 of development of the fetus. It functions as an interim kidney for a first trimester. So is something that is temporary. It does function as a kidney, but it's a temporary kidney that only helps it during the first trimester of the pregnancy, while well, by time it persists in the male as genital system this time, not like a functioning kidney. So by time it loses its function as a temporary kidney and um, transforms into the genital system as Wolffian duct in the male, for example, forming the ductus deferens and epididymis from the Wolffian duct. So the Wolffian duct will develop into the ductus deferens and epididymis. And that is in the male. Well, of course, it develops into something else in the female. I think it was Garnth tube or something like that. Anyway, for that's for the mesonephros. For the metanephros, it's permanent. It is the part that is going to persist throughout life, through adulthood, and after birth, of course. It first appears in week 5 of development, in week 5 of the fetus's age. So the pronephros is normally completed. The nephrogenesis, actually, the nephrogenesis is normally completed by week 36 of gestation, so it starts by week 5, then goes into week 36 of pregnancy. It has two main parts. The first one is the ureteric bud, and the second one is the metanephric mesenchyme. The ureteric bud, that is also called the metanephric diverticulum, is this yellow part over here, is just like a stem coming out of the mesonephric duct, and we know that this mesonephric duct was a main part of the whole mesonephros over here. So this is the whole mesonephros, and then we have the mesonephric duct over here. So when it goes down, it or it goes up, actually it just gives a lateral stem out of it, that is the ureteric butt. So this is the part 1 over here. In this ureteric butt, that is also called metanephric diverticulum, it is derived from the caudal end of the mesonephros. So caudal end means it's the tail part of that system. So this is the head part, and this is the tail part. And yes, we can tell that the urethric bud comes from the tail part, the caudal part of the mesonephric duct. It gives rise by time to ureter, pelvis, calyces, and collecting ducts. So basically, all the um, collecting parts of the renal system. It fully canalizes by week 10 of development. So if we're asked about when does the whole canalization part is considered done and complete in the ureteric bud, that is by week 10 of fetal development. So this is the first part. The second main part, as we said, is the metanephric mesenchyme. The metanephric mesenchyme. So we say here the ureteric bud, here is the metanephric mesenchyme. The second name for the metanephric mesenchyme is metanephric blastema. This part, it looks like this pink circle over here is the metanephric mesenchyme. This is the metanephric blastema, as we said. And we can tell by looking at the image, there is some kind of interaction between this metanephric mesenchyme and the first part that was the ureteric bud over here. So it says that ureteric bud interacts with this tissue, with the metanephric mesenchyme. This interaction induces differentiation and formation of a glomerulus. So this is how the glomerulus differentiates and forms, just by the interaction between the ureteric buds and the metanephric mesenchyme. So the differentiation and formation of glomerulus through to the distal convoluted tubule. So starting with the glomerulus itself, and then with all of the parts going over here and ending in the distal convoluted tubule. So it's to this part. And for our information, there could be a possibility of aberrant interaction between these two tissues, between the ureteric bud and the metanephric mesenchyme. So there's a problem with this interaction, or any defect with this interaction. This is what results in several congenital malformations of the kidney. So if you have a problematic interaction over here, then we are going to have the malformations of the kidney, like renal agenesis or multicystic dysplastic kidneys, and we'll talk about these later. We also have something called the uretero-pelvic junction. So basically, it's the connection between the pelvic part and the, how do I say it? It's just that the collecting system of the urinary system is actually starting as something that collects the urine from the renal tubules. Does it make sense? Okay, we'll take a look over here. It does have a uh-huh. So yes. So this is the pelvis. This is the renal pelvis over here. This is the white thing. This is the renal pelvis, and we were talking as well about the uretero-pelvic. And this whole thing, the rest of it is the ureter actually. Yeah, this is nice. Okay, so if we are having, well, at the uretero-pelvic junction, as we said, it is the last part to canalize. Wow, it's the last part to canalize, and that's why it's susceptible for congenital obstruction. And congenital obstruction in such a situation is going to have a disease. I mean, is going to be considered a problem, a disease. We'll also mention by time. It can be unilateral or bilateral. It can happen either on the right side or on the left side. And these should be instead of each other. Most common pathologic cause of prenatal hydronephrosis. This problem, or this problem with the canalization of the uretero-pelvic junction, of like creating a canal, of completing the lumen of the canal between the uretero-pelvic parts. So this, as it looks like here, it's a canal. So this is a circle, so that urine can flow to this part. So in case there's a problem over here with the canalization of this part, it could be unilateral or bilateral, like with one kidney or with two kidneys. This is what we call prenatal hydronephrosis, because the basically the urine is not going to be able to leave over here because there is a problem with the canalization. So this is called prenatal hydronephrosis, and this can be detected by prenatal ultrasound. This is something that we can see by prenatal screening. For the congenital problems that we have, the first thing we're talking about the Potter sequence. The main problem with the Potter sequence is an issue with the kidneys themselves. So we could have autosomal recessive polycystic kidney disease, um, this is called, or we could have an obstructive uropathy. These are some diseases that we're going to talk about by time, but anyway, for now, let's just know the names. There is autosomal recessive polycystic kidney disease or obstructive uropathy, like, for example, the posterior urethral valves, or we could have bilateral renal agenesis. So, all of these are problems with the kidneys themselves. So, which means the kidneys over here cannot function properly, and because kidneys cannot do their function as they're supposed to, that means they will produce less um, amniotic fluid. So if the kidneys are not producing enough amniotic fluid, it's called oligohydramnios, which means the fluid that that the fetus swims within, like it's within within the uterus of the woman, of the mother actually, the baby is going to have much less fluid to flow into, which means the cover is going to compress on the fetal parts. So, oligohydramnios would lead to compression of the developing fetus. The fetus cannot develop freely because the space he's swimming into or within is just reduced and doesn't have enough fluid. This would lead to limb deformities and facial deformities like low sit ears and retroganthia. Retroganthia is the backward positioning of the chin, of the fetus chin. So this is retroganthia. And also we could have flattened nose. All of these deformities, the facial deformities and the limb deformities, in addition to compression of chest and lack of amniotic fluid aspiration. Well, because the oligohydramnios means there is less amniotic fluid. So there is less fluid going into the lungs, because we know that the lungs during fetal development should be filled with amniotic fluid due to aspiration. But in our case, there is lack of amniotic fluid aspiration into the fetal lungs. That would lead, of course, to pulmonary hypoplasia, and that is the main cause of death over here in the case of Potter sequence. This is caused by chronic placental insufficiency or reduced renal output. Okay, so there's an addition to the problem with the kidneys themselves, there is a main reason over here, that is the placental insufficiency. Okay, placental insufficiency. So we know that the placenta is the attaching part between the fetus and the mother, from where it gets all, the fetus can get the blood supply, nutrients, and everything else that is needed for viability. So if there's placental insufficiency, that means we have the oligohydramnios, or ending up as Potter sequence. So placental insufficiency and reduced renal output, for whatever the reason, and reduced renal output may lead to Potter sequence. And in order to memorize it, it's the babies who can't pee in utero develop Potter sequence. That is the pulmonary hypoplasia, oligohydramnios. That is the trigger, the main trigger over here. Twisted face, twisted skin, extremity defects, and renal failure in utero. And we have page 2 for, okay, let's do this now. The horseshoe kidney, it's the inferior poles of both kidneys fuse abnormally. So we know that normally the kidneys should be separated from each other. Yeah, this is a weird looking kidneys, a very weird looking kidneys. But anyhow, like the lower poles of the kidneys should not be attached together. There should be a space in between. But in our case, the horseshoe kidney, there is the lower poles of the kidneys are attached to each other. So and that is abnormal, of course, as in image A. As they ascend from the pelvis, because we know that the kidneys actually during the development, they don't come down, they actually ascend from below to above. So they start going up when the fetus starts developing until they reach their uh, place, their normal place over here. So during their ascending from below to above, they may get trapped somewhere, and that is below the inferior mesenteric artery, because we know that the inferior mesenteric artery comes out of from the abdominal aorta. So, and they're attached, they're fused together, so they just cannot go up freely, and they get trapped in this place. What it's saying is that as they ascended from the pelvis during renal development, horseshoe kidneys get trapped under the inferior mesenteric artery and remain low in the abdomen, so they cannot overcome this entrapment over here. So that's why they stay low in the abdomen, not in their normal place. Kidneys can function normally, even though they're low, even though their lower poles are attached to each other, but they still function normally, and this is great. But it is associated with hydronephrosis. Well, we know the hydronephrosis is happening in this case. For example, okay, urethral pelvic junction obstruction. So the hydronephrosis means the urine within this lung. What lung? The urine within this kidney is unable to leave the kidney due to a problem within the pelvis over here, for example. So this is hydronephrosis. So we could have this in the case of horseshoe kidney because we could develop urethral pelvic junction obstruction, and this is something that we talked about over here. We could have a problem within the junction of the renal pelvis and renal ureter, leading to hydronephrosis. So this is something that we could have here. And also the horseshoe kidney predisposes the patient to renal stones and increases susceptibility for infections and increased risk for renal cancer. The higher incidence, it happens more in patients with chromosomal aneuploidy, like Turner syndrome, trisomy 13, 18, and 21. And this is the horseshoe kidney. So this is the aorta, and this is the inferior vena cava, while the horseshoe kidney is just, they are attached to each other over here. So we have the right kidney and left kidney, but there is no separation at all between them. So it's quite obvious. The other disease is the congenital solitary functioning kidney. In this case, we are having, well, as the name implies, this is congenital, so it's not acquired. We can see this when the baby is born. It's solitary, so there is one functioning kidney, not two. We require two, actually. Normal people has two, but in this case, we have one functional kidney. This is the condition of being born with only one functioning kidney. Majority are asymptomatic, don't have any symptoms, with compensatory hypertrophy of contralateral kidney. Of course, because we need now there's only one kidney, so we need it to do extra work, just like the other one is still there, so it needs to overwork itself. That's why, because it's overworking itself, it goes into compensatory hypertrophy to compensate for the non-existence, or actually maybe some existence, but for the non-functional other kidney that may or may not exist. But anomalies in the contralateral kidneys are common, um, often diagnosed prenatally by ultrasound. Well, even though now that we have one kidney, but still this one kidney could have anomalies. So often diagnosed prenatally via ultrasound. Well, these anomalies, if you think about it, then I think it could happen, as they're saying, in the contralateral kidney. So that's the non-functioning kidney. Okay, so the functioning kidney undergoes compensatory hypertrophy, while the non-functional kidney, if it exists, then it could develop a lot of anomalies. Okay, and this is something to be diagnosed prenatally via ultrasound. There are two main subtypes: unilateral renal agenesis or multicystic dysplastic kidney. For the first part, there is the unilateral renal agenesis. So renal agenesis, which means just not there. So the ureteric bud fails to develop. So the problem is with the this ureteric bud, this little stem that is coming from out from the mesonephric duct. So it fails to develop and induce differentiation of metanephric mesenchyme. This leads to complete absence of kidney and ureter. So in this case, there is completely uh, one kidney. There's complete loss of the other kidney and its ureter, because ureteric bud fails to develop and fails to induce the differentiation of the metanephric mesenchyme, and it is this pink circle over here, pink ball over here. That's for case one. For case two, there is the multicystic dysplastic kidney. Multicystic dysplastic kidney, and I think it's, as the name implies, it's ureteric but develops. So in this case, the ureteric but does develop, okay, but it also fails to induce the differentiation of metanephric mesenchyme. So it exists over here, okay. It exists over here, the electric bit, but it fails to induce this pink ball over here. That is the metanephric mesenchyme. This will lead, of course, to non-functional kidney consisting of cysts and connective tissue. So because this part is not abnormal as well, because there is no differentiation of metanephric mesenchyme, that means there is a non-functional kidney consisting of only cysts and connective tissue. Predominantly non-hereditary. Okay, so this could be non-hereditary, not could be, this is predominantly non-hereditary and usually unilateral. So it's only on one side of the body, so only affecting one lung, one, oh, why do I keep saying lung? It's affecting only one kidney. Bilateral leads to Potter sequence. So if it happens, unfortunately, and affects both kidneys, and that is the bilateral, it will of course lead to Potter sequence, because both kidneys are not functioning well, so no one of them is compensating for the other one. So now of course we have the Potter sequence. For the duplex collecting system, for the duplex collecting system, as I said, there is bifurcation of ureteric bud before it enters the metanephric blastema, creates a Y-shaped bifid ureter. Okay, so this is the ureteric bud, as we know, and it should go normally as one ureteric bud into the metanephric mesenchyme, that is this pink circle or tissue over here. But what is happening in this case is that this ureteric bud develops into two, bifurcates into two ureteric buds before actually going into the metanephric mesenchyme. So that's why it's called duplex collecting systems. That's the bifurcation of ureteric bud before it enters the metanephric blastema, which creates a Y-shaped bifid ureter. So this is the kind of Y. Yeah, this is the Y-shaped ureter. Duplex collecting system can alternatively occur through two ureteric buds reaching and interacting with metanephric blastema. So what is happening here is that these two separate or two actually attached in the base ureteric buds, they are reaching and interacting both with the metanephric blastema. This is strongly associated with vesicoureteral reflex and or urethral obstruction. Wow, strong associated with vesicoureteral reflex. So whatever the problems that it's happening, it has an issue with the ureters. Okay, so either it's vesicoureteral reflex or a urethral obstruction. This, of course, increases the risk for UTIs and frequently presents with hydronephrosis as well. Okay, that's for the duplex collecting system. Now for the posterior urethral valve. This is a membrane remnant in posterior that is the prostatic urethra in males. So this only happens in male babies. There is a membrane that should go away, but it stays there as remnant in the posterior, that is called the prostatic urethra, in the posterior urethra. Its presence can lead to urethral obstruction because, I mean, quite obvious. There is a membrane obstructing a lumen. So, yeah, there you go. So its presence can lead to urethral obstruction, diagnosed prenatally by bilateral hydronephrosis and dilated or thick-walled bladder on ultrasound. So we can see either bilateral hydronephrosis, this is what we could see on ultrasound, or we can see thick-walled bladder as well. Okay. Severe obstruction in fetus associated with oligohydramnios. Okay, so if this obstruction was way too severe in the fetus before being born, that would lead to hydramnios, oligohydramnios, because the lungs. Wow, again, the kidneys, not the lungs, so that the kidneys can actually produce urine, and the urine is going to be considered as the amniotic fluid. So in our case, because there's severe obstruction, the amniotic fluid is not going to be as much as it's supposed to be, and this is called oligohydramnios. Most common cause of a bladder outlet obstruction in male infants. Well, this is important because it's the most common cause for bladder outlet obstruction in male babies. So it doesn't happen in females, it's only male babies. And this is it. So this is normal. Here's the kidney. Nice, sweet kidney. And then ureter over here. And then the bladder over here. And everything's fine. This is urethra. This is fine. Well, in our case, there is obstruction. See this nice white lumen without any problem. But in the posterior urethral valve, there is this membranous remnant over here obstructing the outlet of urine to the outside of the body, which leads to hypertrophied bladder wall and distended bladder, of course, and then the urine should will go up while it is supposed to only go down. It's supposed to only go this way, and it should not go this way, but it's happening. So there's also hydroureter now and hydronephrosis, that is the collection of the fluid all over or backing up into the kidney. This is the posterior valve. And the main problem, as we said, is the urethra obstructed by posterior urethral membrane, and this is the teeny tiny part over here. Okay, so for the vesicoureteral urethral reflux, this is a retrograde flow of urine from bladder toward the upper urinary tract. Well, it looks like kind of look like this. We know that the blood should. Let me take. Okay, so the blood should go only, not the blood, this is the urine. It should go only down. It should only go this way. But in our case, it backs up and goes abnormally upward. So the retrograde, that is the retrograde, like going up against its normal flow. Retrograde flow of urine from bladder towards upper urinary tract. From the bladder, as I draw here, to the upper urinary tract. This can be primarily due to abnormal or insufficient insertion of ureter within the vesicular wall, and that is the uretrovesicular junction, or secondary due to abnormally high bladder pressure resulting in retrograde flow over via the uretrovesical junction, and increases the risk for recurrent UTI. So there could be two main reasons over here. So it's either a primary, there's a problem with the insertion of this ureter into the vesicle over here. So there's a problem over here. The problem with the connection between the ureter and the bladder, and that is considered primary, called the uretrovesical junction problem. Okay, or it could be due to secondary cause. That is the problem. The issue is not with the ureters or their insertion, it's because this bladder has a very high pressure inside that is preventing the urine to come into it, and then the urine backs up So the problem is within the pressure of the bladder, and this is called the secondary cause. Uh, the risk for, and well, of course, because the urine backs up, then it definitely has a higher susceptibility of UTIs. So there are recurrent UTIs, and that's it for the embryology.